it's being evident since yesterday. We have been discussing locally advanced thyroid cancer, right? So this locally advanced thyroid cancer is such a headache. For I think Dato' Imi would agree with me. For the consultant level, large thyroid, no complication. Yes, everybody can do. We normally would just stay in the room, let the fellow do all the cases. But when we have this locally advanced thyroid cancer, then where the challenge starts, the adrenaline starts. And sometimes we keep pondering what is the best management for these cases. So it is not easy. So I will slowly and try to get the core digest for this presentation. Come on. All right. My presentation would be on the locally advanced thyroid cancer, about extrathyroidal thyroid tumor extension, the management, innovation management, and also the summary of it. So what is locally advanced thyroid cancer? This is when the primary tumor passes the thyroid capsule, infiltrating the surrounding tissues, right? When we talk about extrathyroidal tumor extension, it has a significant negative impact. First, it will give rise to high risk of local recurrence, regional spread, and distant metastasis. And in 10 years survival rates of 45% versus 91% in patients with no extrathyroidal extension, especially in older patients and those with aggressive histological features. There are differences between the AJCC 7th edition and the 8th AJCC edition, whereby in mainly with regards to the age, 45 versus 55, and you can see there is no more stage 4C for the 8th edition, and the stage 3, stage 4 also differs, as you can see inside the presentation, inside the slides. Now, with regards for the locally advanced thyroid cancer, strap muscles constitute the most, which is around 53%, followed by 47% of recurrent laryngeal nerve and 37% with regard to the tracheal. The rest is as follows. Most of the time, the extrathyroidal tumor extension is from the primary tumor and also from the lymph nodes. So what are the features of thyroid cancer associated with poor prognosis? First is the extrathyroidal tumor extension. Second, when the tumor is large, it makes sense. When tumor is large, it shows that it has a poor characteristic features. The aggressive tumor histology is also important. That's why for my trainees, I always stress that you guys have to have a good pathology knowledge, because sometimes when the FNAC came back as a papillary, but the features are all shows toward locally advanced thyroid cancer, this might not mean that this is a simple PTC. You should also think about those that have a poor characteristic features, like hobnail type, like the insular type, tall type. So these might have give an impact for the management. And also, thyroid cancer can have a distant metastasis, commonly in the lymph nodes, but PTC with poor characteristic features can have distant organ metastasis. And also, if patient present with older age. So, management. First and foremost, right, you have to remember, when there is a local disease, the problem is it can causes morbidity and mortality than most of the, and more than the distant metastasis. So that's why you have to tackle the local original problem. If there is a huge thyroid, because it inevitably will cause airway obstruction, it can cause nerve problems, and also any surrounding important structures. And by doing that, sometimes it gives better response to the adjuvant therapy after surgery. Now, the pre-op assessment. So it is important to have a thorough history and physical examination for signs and symptoms of locally advanced thyroid cancer. At your level, don't just consider normal voice. Patient doesn't complain of normal voice. It does not means that the nerve is spared. Probably because the affected recurrent laryngeal nerve may have a compensation from the contralateral functioning vocal cord, right? And then the history must be also not, the history should be more. Sometimes whether the patient has cough, stridor, hemoptysis, right? When a patient got hemoptysis, probably there is intraluminal invasion towards the trachea, and this has caused bleeding. Patient can have aspiration, right? And patient might also has dysphagia, tumor compression, or invasion of the pharynx and also esophagus. What about imaging? When there is a locally advanced thyroid cancer, you have to do an imaging CT scan to proper plan your surgery, whether it's resectable or not. So people will ask, what about its value with regards to when you give CT scan, you do CT scan, what about you are going to do RAI? We're going to delay the RAI. But in this case, the value for CT scan is far outweigh. The value is far outweighs the concern about IV contrast. So just do a CT scan and you can have a good image evaluation. Right. So the principles of surgical management first is to remove all gross tumor disease. That's the number one. Your principle. If you want to do surgery, you need to remove all gross tumor. Second, you want to preserve functioning and vital structures. Okay. And the third one is this patient inevitably need to have an appropriate use of adjuvant therapies, be it RAI or radiotherapy. So in the general approaches of the management of these structures, you need to resect the invaded structures to obtain clean margins, either shaving or tangential excision procedures, followed by adjuvant therapy. For doing this, it is important to have an preoperative evaluation is very, very important. Now, you need to have a pre-op discussion between the ENT, the anesthetist, and the surgeons. First, because there is sometimes the airway is distorted. There is a paralyzed vocal cords. The trachea might have involved with the tumor. And for the anesthetist, they need extra precautions needed, whether they need to have an awake fiber optic nasotracheal intubation in a compromised patient, or probably they need to have a jet ventilation before surgery, before they can introduce the ET tube. Or probably this patient needs to have a tracheostomy before surgery. Right. The first one is the strap muscles. For the strap muscles, there is no issue because it entails no significant morbidity because it is similar to those with no invasion. Just remove in total with the strap muscle. This is if only strap muscle is involved. What about recurrent laryngeal nerve? So when you have a recurrent laryngeal nerve, it can be either from the tumor or from the lymph node itself. So there are three situations. First, if recurrent laryngeal nerve is preoperatively known to be paralyzed and confirmed intraoperatively to be invaded. So what shall we do? The nerve should be resected, right? In a patient with a preoperatively paralyzed recurrent laryngeal nerve, but intraoperatively it's found to be not invaded, just compressed. And the tumor can be safely removed from the nerve, and the nerve can be preserved. So just probably you don't have to cut the nerve. because it's possibility the vocal cord can recover after surgery. But if recurrent laryngeal nerve invasion with intact vocal cord function preoperatively, so what can we do? So it's a dilemma to reserve, to reset versus to spare the nerve. If the nerve preservation requires gross disease to be left behind, the nerve should be resected. If the tumor can be peeled off from the functioning nerve in order to achieve R1 resection, probably it may be attempted because post-operatively, you can give RAI for this patient. Nerve monitoring is important before recurrent laryngeal nerve resection. By using nerve monitoring, you can check whether the opposite nerve should be carefully checked to assure functions, because bilateral vocal cord paresis may lead to tracheostomy if the anesthetist is not careful enough. If they want to remove the ET tube after surgery straight away, that might give a problem for a patient. Probably, as what the Prof said yesterday, probably this patient should need to be sent back to PAKU, intubate overnight. The next day, probably slowly remove the ET tube. Right. Immediate nerve repair can be performed by either primary anastomosis or resected recurrent laryngeal nerve. If no nerve repair, probably the nerve can be repaired later, either by vocal cord implants, right? Or vocal fold can be injected during laryngoplasty. All right. For the trachea, a significant independent factor for survival is laryngotracheal invasion. However, laryngotracheal invasion is rare. It's about 12%. There is no clear guidelines to show how to manage surgical options. It's either to peel it off or do a partial or total laryngectomy. This depends on the extent of surgery, right? The management depends on the extent of cartilage involved and differs between the cricoid and the thyroid cartilage. If the cricoid is involved, involvement of 1/3 of the cricoid resection without need of complex reconstruction or tracheostomy. However, if more than 1/3, more extensive surgery is needed, which is total laryngectomy to avoid airway stenosis and partial laryngeal resection with formal laryngotracheal reconstruction. Okay, everybody knows about this, the Shin classification. What shall we do about Shin 1? It is better to just shave. Shaving of the tumor which has not invaded deeply to the tracheal wall, because mobility and with tracheal resection and risk of complication of, if you try to resect, the risk of tracheal stenosis. So there is a study by Nishida whereby in a stage 1 tracheal invasion with shave procedures compared to those who have locally advanced thyroid cancer with no airway involvement, actually there is no difference in local original recurrence, distant metastasis, and overall survival. Patients who initially undergo shave procedure, disease-free survival and overall survival than those who undergo complete resection at initial presentation. So when do surgery, you need to discuss with the NT, head and MDT, and need to consider the histology of the thyroid cancer and what is the plan after that. In stage 3, in stage 2 and stage 4, the extent of operation depends on the circumference and the extent of the trachea. Usually limited involvement of an anteriorly or laterally located tumor, and involvement of the last 1/3 of trachea circumference, a wedge resection might be sufficient. All right, this is a tumor. We can see there is a tumor, large intraluminal tumor in the trachea. Using jet ventilation, patient is already under GA. Using jet ventilation, we the ENT would our ENT colleague would do endoscopic resection, right? To remove the tumor intraluminally, because we don't want to put straight away blindly put the ET tube because the tumor might dislodge distally. All right. And then when it's clear enough, then we put the ET tube. And then we can do a wedge resection over that area. And then that area you can put tracheostomy. Right? Okay. And this is the tumor with the part of the trachea which has been removed. For stage 3 and stage 4 tracheal invasion, more than 1/3, where more than 1/3 of the trachea circumference, you can do a resection of at least one tracheal ring. Okay. And primary anastomosis can be done with a circumferential or sleeve resection of as many as 7 to 8 tracheal rings or 5 to 6 centimeters. Right. What about esophageal or pharyngeal or esophageal? Direct extension with tracheal invasion will usually extension from the paratracheal or paraesophageal nodes. When you have a pharyngeal or esophageal invasion, usually it signifies poor prognosis, and invasion rarely invades more than the invades to the mucosa, because mucosa of the pharynx and esophagus forms as a protective layer, right? However, one of the important investigation is endoscopic ultrasound pre-op imaging to determine thickness of the invasion, and it allow appropriate surgical planning, right? For the esophageal and pharyngeal, the first thing is we need to decide the thickness of the invasion. If it's just quite superficial, you can do just a simple resection of the involved muscularis, and its full thickenment. Closure of the defect can be done by can be performed as long as you can have closure is not under tension, and also patient would not have radiotherapy after that. And the primary closure should be done as watertight and multi-layer. All right. All right. What about carotid artery? The carotid, when you have a carotid involvement, usually it has already advanced. If the tumor can be peeled off from the carotid, by all means you can remove. But if it's more than 270% degree involvement of the carotid, it it's contraindicated, and most often it already the disease has already in advanced stage, and curative is rarely achieved. All right. Now, after doing the surgery, then you need to have adjuvant RAI. You can have radiotherapy. With regards to radiotherapy, there are two schools of thoughts, right? Two schools of thoughts. Whether to give radiotherapy as an earlier part after surgery, or to give radiotherapy after RAI, right? The first proponent is the second proponent is why we want to give a radioactive radiotherapy after RAI, because they want to check if they give RAI but there is no uptake, so this is probably locally advanced thyroid cancer. This is probably non-radioactive FA, right? So for the first proponent, why people would do radiotherapy straight away, right? Because technically, these are the cases with locally advanced thyroid cancer. They are aggressive, and most of the time, these are poorly differentiated thyroid cancer. So the modality, the most important modality is to give radiotherapy, because you tend to leave behind a lot of thyroid tissue. So technically, this patient need to have radiotherapy and then to give RAI, right? Furthermore, RAI, it's difficult to get RAI at an earlier stage. But however, I tried to find out within the literature review, there is no study to compare between this and this. I mean, it's logical. It's difficult to have a study for this. All right, now, my few last slides is regards to what about neoadjuvant TKI. So, first case yesterday, TKI. Second case is TKI. This is because in 2010, Mr. Cleary has reported the first neoadjuvant treatment for medullary thyroid cancer with sunitinib. So this is the first one. And after that, everybody get excited. Okay? So why to give neoadjuvant TKI? To downstage the tumor, making inoperable cases operable. 2, to increase the R0 to R1 resection rate in cases where there is a R2 resection. 3, to preserve the function of the vital organs and improve the quality of life after tumor shrinkage. 4, for tumor with distant metastasis, local surgery after neoadjuvant therapy can provide patients with opportunity to receive RAI. 5th, to observe the drug sensitivity and the guide systemic therapy after that. In 2022, this is the first systematic review on adjuvant TKI. They involve 16 studies. Just imagine, actually 65 studies, but they have all these criteria. And out of 16 studies, 32 patients, whereby they include everything. 18 differentiated thyroid cancer, 3 medullary, 8 anaplastic, and 3 poorly differentiated thyroid cancer. Majority of these are stage T4A and T4B, and 81% have regional lymph node metastasis. And the average duration of TKI treatment was 4.3%. So they found out after giving neoadjuvant therapy TKI, 4 did not receive surgery after neoadjuvant treatment. 2 cases were still not resectable. 2 cases refused surgery. And 1 patient received surgery. However, the status of the margins are not provided. So 27 patients had surgery, and the proportion of R0, R1, and R2, R1 is microscopic, R2 is macroscopic, were 59.3%, 33.3%, and 4.7%. And the R1 resection rate for intention to treat population was 78.1%, which is promising. So these cases were followed up for 12.1 months after surgery. Only 1 died. So what's the issue about this neoadjuvant TKI? There is no consensus on the time to stop targeted drugs after surgery. Decision based on drugs adverse events, drug half-life, complications of surgery, etc. And what about the maintenance of systemic therapy? Differentiated thyroid cancer patients with complete surgical resection, RI treatment or regular follow-up should be performed according to the guidelines. However, do we want to restart again TKI? Once they have stopped the TKI, would TKI give a better survival in this cohort of patients? Nobody knows, right? But we do know common adverse events were hypertension, hypertriglyceridemia, proteinuria, cholesterol elevation, and hand-foot syndrome. So in summary, surgery is the primary treatment modality. Resect all gross disease and minimizing morbidity. You have to have a dedicated thyroid surgeon, endocrine surgeon to handle this. This is not a job for, I believe this is not a job for general surgeons, right? The conservative approach in patients with minimally visceral invasion, you should have shave procedures to remove the macroscopic disease, and the residual tumor can be managed with adjuvant RAI or radiotherapy. In thick mural invasion, full thickness resection is recommended if possible. In distant metastasis, surgery still play a role, although cure is unlikely. Total thyroidectomy with subsequent RAI and to reduce airway compromises. Okay. Summary about neoadjuvant TKI. Neoadjuvant targeted therapy has a new treatment option for locally advanced thyroid cancer, and they might improve the R0 to R1 resection rate in selective cases. However, more clinical trials with longer follow-up time are needed to confirm the clinical benefits of neoadjuvant targeted treatment. Thank you very much.
Very much.
Sekejap.
On the floor, have any question?
Okay, ini.
Not enough time. Oh, maybe later. Yeah.
All right. I would like to take this opportunity to give we are going to host the breast surgical ISW International Surgical Week, whereby UKM will host the breast ultrasound. This will be organized the Breast Surgical International in conjunction with the ISW 2024. So we are going to have 50 seats, 50. So the price is, if you are a member of BSI, is around 750 ringgit Malaysia. Kalau dalam US dollar, I tak ingat lah berapa. Ada tak situ? Okay. 700. Okay, kalau non BSI, tinggi. So the committee requested, kalau boleh rakyat Malaysia ramai mendaftar. Okay, for this breast surgical international ultrasound workshop. Okay, this will be by few surgeons from, if I'm mistaken, from UK, from Switzerland, from Hong Kong, and from Australia, if I'm mistaken. All right. So please take note, especially for fellows. Okay. This is what I think I would discuss back with Miss Prof. Miss Anita. I would like to know who are coming, how many are coming. Probably we try to get breast chapter to sponsor, but I cannot promise 100%. Probably 50% itu pun okay lah. Okay.
Thank you, Shahrun, for sharing this some cost. I think this is the time when the trainees should be involved, because it will be organized by a well-known breast surgeon such as Shahrun Chan from Hong Kong, in which they are very well known in the world. So grab this opportunity, put up your name, and then maybe if we have so many of you interested to join, we can do something with breast sector so that they can just sponsor you, or maybe partially sponsor. Please give the name to one of the siapa yang nak menjadi ketua ni. Please nanti betul ketua among yourself, and then give the names to Prof. Shahrun. Yeah, thank you. So without further ado, I would like to invite Miss Anita for the next talk, titled Career Plan Imaging and